Hyperthyroidism lab diagnosis, interpreting blood work and radioactive iodine uptake test. So I'm putting this together for people with hyperthyroidism who maybe can understand the blood work when they get their initial diagnosis, but as they go through some type of treatment plan, whether that's the conventional plan or using natural therapies, they're going to see a lot of these labs change, and there really isn't much education upon how to interpret the labs as they change, as someone hopefully gets better. Just to quickly review what the labs will be, in the brain we have TRH, thyroid releasing hormone, and that stimulates the hypothalamus and pituitary, which here I just kind of put together for the sake of simplicity. And that in the brain, the base of the brain, the hypothalamus and pituitary will make TSH, or thyroid stimulating hormone. And TSH tells the thyroid to make more thyroid hormone. And then on the lab work, you're going to see T4 and T3, and that's the actual thyroid hormone. So all you have to know is that the TSH is how much stimulation the brain is sending to the thyroid, and then the actual thyroid hormone levels will be in the T3 and T4. We have a conventional reference range for TSH of about 0.5 to 4.0. And, to really interpret these tests with nuance, to understand more what's going on an individual level and where they are in terms of recovery or possibly getting worse, this reference range is really close to useless. An optimal reference range is about 1.5 to 2.5, and I'm putting the about sign there because some people will be in their optimal, range, and they might be a little bit outside of that. But typically, if someone has a TSH of like 0.6 or 3.6, something like that, it means that something is off. And if you just clump everyone together from 0.5 to 4.0 as normal, that's really turns into a meaningless designation, and it creates a lot of confusion when it comes to really interpreting these tests with any sort of nuance. This chart covers the 4 possibilities of where we could be with TSH and thyroid hormone. When I say thyroid hormone, that would be the test for T3 or T4. If someone has low TSH and low thyroid hormone, that's going to represent some type of functional hypothyroidism. Those are people who have many symptoms of hypothyroidism, but they don't have an autoimmune disease. Typically, they will not do good on thyroid hormone replacement, but nonetheless, online they might get that advice anyway. That's a little different topic than the hyperthyroidism. You can have elevated TSH, indicating that the body wants to try to produce more thyroid hormone with low thyroid hormone, and that will typically be autoimmune hypothyroidism or Hashimoto's. That could also be due to low iodine. Then going to the high thyroid hormone or hyperthyroidism, typically we're going to see the thyroid hormone elevated, but TSH will be suppressed, pretty low. So that's usually what we're dealing with. That's going to be, Graves' disease, thyroiditis causing hyperthyroidism, thyroid nodule, all that. If someone happens to have elevated TSH and high thyroid hormone, then they're going to have to go to an endocrinologist for that. That would indicate some type of possibly pituitary tumor making TSH. That would be a very unusual pattern. On this slide, we're going to start getting into some of the nuance with interpreting the labs on an individual level. And at this point, you can see that this simple interpretation of saying if TSH is low and thyroid hormone is high, that's hyperthyroidism, that really isn't adequate, because there are varying degrees of how bad this hyperthyroidism is. So we need different basically diagnoses to represent the different degrees of severity. So the most severe case is going to be TSH of about 0.1, which is totally suppressed, and T3, T4 thyroid hormone is elevated. And that situation, you can go into a medical doctor, get a diagnosis of hyperthyroidism, get your prescription of a drug such as methylmyazole, or tapazole, or propanadol to control symptoms, and then possibly have an endocrinologist lead you down the road to having, thyroid ablation, and all that. But what about the person where their TSH is also 0.1, but their thyroid hormone is not elevated? It's actually high reference range. Now that person might go in with a couple of symptoms, but then they might be told, hey, it looks like you have a problem, but you're not really bad enough for all this stuff. So let's just, wait and see what's happening. Let's just watch it. And then you have someone else where their TSH is actually in reference range. It's about, say, 0.6. And maybe their thyroid hormone is also in reference range, but it's kind of high reference range. We can see this person is leaning towards hyperthyroidism, but they're not actually there yet. And the thing is, as someone is getting better, they might go through these different stages. But if the only interpretation they have is yes, hyperthyroidism, no, normal, then they're not going to be able to interpret these changes. They're not going to know what to expect in terms of the lab work as they either get better or worse. So we have to ask the question of what does a TSH of 0.1 really mean? And when I say 0.1, I don't mean literally 0.1. It could be any number around there that indicates that the TSH is just about entirely suppressed. So normally the thyroid gland will only make thyroid hormone under the stimulation of TSH. As soon as your body has excessive amounts of thyroid hormone, and this could be slightly excessive or extremely excessive, as soon as there's just a little bit more than what your body really needs, the brain, hypothalamus, and pituitary are going to sense that, and they're going to lower TSH. So basically, a TSH of 0.1 means that the thyroid gland is auto-generating thyroid hormone by itself. That doesn't need TSH. It's indicating that there is something going on with the thyroid itself auto-producing thyroid hormone. And that's all that this 0.1 number means. It does not indicate by any stretch of the imagination how bad hyperthyroidism is, and we're going to get right into that. This is a chart of the relationship between TSH and thyroid hormone as hyperthyroidism develops. So the left side of the chart is just TSH, and the bottom is how much thyroid hormone someone has. And I'm really starting this chart at normal. So if someone is kind of healthy, then they'll be all the way at the left side of the chart. Their TSH will sure be 0.75 or above, and we'll say that normal thyroid hormone is all the way at the left side of the chart. As their thyroid starts to produce more thyroid hormone, the TSH is going to go down. So we're going to have this range where TSH is, say, 0.75 or less, but not all the way suppressed, where they're not really healthy, but not bad enough for an official diagnosis. And this is going to be more in that subclinical hyperthyroidism range. And then when they get bad enough, their TSH will go all the way down to about 0.1, and that's where they're bad enough to be diagnosed with hyperthyroidism. So a really huge point in interpreting hyperthyroidism and TSH is that regardless if thyroid hormone is elevated just slightly out of reference range, or if it's 4 times greater than reference range, TSH is probably going to be about 0.1. So once you pass that threshold point where the hypothalamus and pituitary just says, that's it, the thyroid isn't getting any more thyroid hormone, we just want to stop this, as soon as you pass that threshold point, TSH becomes absolutely worthless in terms of understanding how bad hyperthyroidism is. The only thing it's saying is that the thyroid is auto-generating excessive thyroid hormone. It doesn't say how excessive it is. And this becomes important when people are going through some type of therapy, whether they're using a medication or whether they're using natural therapies, where they might start to feel better, their actual levels of thyroid hormone might improve, but their TSH remains at 0.1, and then they're upset because their TSH isn't changing. Well, if you want to see your TSH change, you have to get the thyroid working well enough so it needs additional TSH stimulation because the body wants more thyroid hormone. So that's going to be the last thing that changes. So while going through treatment, it's possible to see a significant drop in thyroid hormone and symptoms, yet no change in TSH. And the best I can say is don't be upset when this happens. This is expected, that TSH is going to change last. So then you might be thinking, if TSH isn't a great marker of how bad hyperthyroidism is, you can still look at T3, T4, or thyroid hormone itself to tell. But due to numerous factors such as genetics, medications, binding of thyroid hormone to thyroid binding globulin, and variations in how sensitive people are to T3 and T4 at the cellular level, well, some people may have numerous hyperthyroid symptoms despite mildly elevated thyroid hormone, and others will have markedly elevated T3, T4, and very mild symptoms. And so in other words, some people are just more sensitive to elevated thyroid hormone than others. So you can't just look at a lab and just look at the T3 and T4 and correlate that exactly to how bad someone's symptoms are. I've seen people with very bad symptoms with hardly elevated thyroid hormone at all, even in reference range. And there's people walking around with thyroid hormone like 3 times out of reference range, and they're saying they really don't feel any symptoms at all. We even have something called euthyroid hyperthyroxemia, and that's abnormally elevated thyroid hormone with little to no clinical thyroid disease. So the labs are important, but you really have to take the labs and interpret them in context with symptoms and the overall case. So some key points is that TSH will only go up when the thyroid stops producing excessive thyroid hormone, and the labs must be interpreted within context of each individual case and individual symptoms. You don't only look at symptoms, and you don't only look at labs. You really have to look at everything. Not for everyone, but for some people, the breakdown of free and total T3 is very important. So the thyroid primarily makes T4, which is a less potent form of thyroid hormone. And then in the periphery, T4 is converted into T3, which is much stronger. So how much thyroid action you have is primarily a result of how much active T3 you have in the blood. But it becomes a little complicated because T4 doesn't just go to T3. It can go to T3 or something called reverse T3, which is a mostly inactive form of thyroid hormone. And then of the T3 that you do have, it's not going to be active unless it's free in the blood, which means it's not bound to something called thyroid binding globulin. Thyroid binding globulin is a hormone in the blood which binds to thyroid hormone, so the thyroid hormone can't do anything. So with many of our hormones, not just thyroid, there are these binding globulins, and the binding has to be undone to make the hormone active. So some people may have very, very elevated T3 levels, but if they have their free T3 tested, then it could be much lower, or even like reference range, or close to reference range. So it's really best to test all the hormones. You want to test both T3 and free T3, because some people just have that pattern, and they might not have many symptoms even with very high thyroid hormone or T3, and you can start making sense of why they don't have so much bad symptoms when you actually look at the free T3 and you realize that's pretty much lower. Let's go over the antibodies, and these are going to apply to autoimmune thyroid disease. Remember, there are other causes of hyperthyroidism, which is why it's important to have these antibodies tested. If you have hyperthyroidism and the antibodies are negative, then it's important to look for other causes of it, because this can affect what treatments make sense. So we have something called thyroid stimulating immunoglobulin, and in some labs you might read TSH receptor antibody, which is basically the same thing. If this is elevated, well, this means that you have the antibody that causes autoimmune hyperthyroidism, and that's what Graves' disease is. Now, many people with Graves' disease will also have the other thyroid antibodies elevated, and that's TPO, or thyroid peroxidase, and thyroglobulin antibody. So any combination of these, if you have TSI elevated, that's Graves' disease. If you have both elevated, Graves, if you only have the thyroid peroxidase or the thyroglobulin antibody, then that's going to lead towards a diagnosis of autoimmune hypothyroidism or Hashimoto's thyroiditis. Often the endocrinologist will recommend what's called a radioiodine iodine uptake scan, or an RAI-U. In this, the patient swallows radioiodine, and then imaging tests are used to measure the amount of iodine taken up by the thyroid. And the imaging, you can see if the iodine is taken up evenly throughout the entire thyroid, or you can see if it's just taken up in certain nodules. So if it's generally taken up by the entire thyroid, then that's going to be positive for something like Graves' disease. It could also be positive for iodine deficiency. I mean, there are some other illnesses, but typically when they see this type of diffuse or even uptake of iodine, you're going to get diagnosed with Graves' disease. Now, this can be used to help differentiate Graves from other causes of hyperthyroidism, such as nodules that can auto-secrete thyroid hormone, and that could be very important because that can really play a big impact on what therapies are going to make sense and what aren't. Honestly, what I've seen is that the natural treatments that I use for people who have Graves' disease, well, those treatments do not necessarily work with some other causes of hyperthyroidism, especially nodules. So at this point, I really don't work with people who have hyperthyroidism from a nodule. So there are cases where this test could be helpful because this differentiation between Graves or a nodule or some other cause can be very important. Of course, the big thing that people are always worried about with this test is that the patient must consume radioiodine, and many patients really don't feel comfortable about that. And when you're in the world of conventional medicine and this test, you will be assured by everyone that there are no ill effects, no side effects, no detrimental outcomes at all to taking the radioiodine and having them do this test. Really, the only alternative discussion that I have seen about this test and possible dangers comes from the excellent book Advances in Graves' Disease and Other Hypothyroid Disorders by Elaine Moore and Lisa Moore. And that if you want a book that covers everything you need to know about hyperthyroidism, that is the book to get. And some key points is that the radiation someone is getting is comparable to that of an X-ray. And when it comes to radiation, X-rays, and ill effects, it can take years or decades to possibly manifest the symptoms. And there are no long-term population studies of those who have had the RAI-U test. So if it comes to the question of, is there a long-term negative effect of having this test done that will only manifest years later? Well, that's really unknown. So it's somewhat disingenuous for people in conventional medicine to say that this test has been definitively proven safe if the research hasn't been done to actually show that. Short term, it does seem pretty safe, but it is a bit of a question mark. And so, my take on this is, if someone really needs to have the test done, sometimes you need to have that test done to get the information. But I don't look at it as a type of test that someone should just necessarily just do, because it's faster than getting the results from blood work. So if it's done, at least I recommend people, get it done for a reason. I can't give people orders. If someone's going to a medical doctor and they're told do this, and then they come to me legally, I can't, change the medical directives, but I try to give people as much information as I can so they can make the best choice possible. So this is basically my answer, that it is uptaking radiation, but it's not really known what the long-term effects of that are. Something that does confuse me is, when do endocrinologists recommend this test and when do they don't? Because I've seen enough people with Graves' disease, and I don't see any pattern in who is recommended to have this test done and who isn't. I've seen people with pretty severe symptoms and they have a diagnosis just made based upon antibody tests. I've seen people with very mild symptoms and immediately it's recommended that they have this test done. So it really is coming down to the clinical judgment of the endocrinologist. Keep in mind that Graves is the most common cause of hyperthyroidism, and if antibodies are elevated, then it is the most likely diagnosis. But exactly why this endocrinologist might recommend you get RAI scan done and another one may not, I'm not an endocrinologist, so I cannot answer that question. So thank you for watching my video. I do have another one on hyperthyroidism posted about 2 years ago that many people have watched, so I'm going to link to that here. I'm going to link to another video about Graves' disease made by another naturopathic doctor who, it's a nice video, so I'm sharing it. That doesn't mean she endorses me, but I do like this video that she put together, and also you can check out my website for more information. And thank you. Bye.